Welcome to The Explainer. Today, we're tackling a condition that's incredibly common in hospitals all over the world, acute kidney injury, or AKI. Now, you'd think defining a medical condition would be pretty straightforward, right? But what you're about to see is that the story of AKI is all about evolving science, some serious diagnostic detective work, and a whole lot of real-world messiness. Let's get into it.
So the very first clue to understanding AKI is actually in its name. For the longest time, we called this acute renal failure. But failure, that sounds so final, doesn't it? It implies a total shutdown. And what researchers realized is that even small, less dramatic dips in kidney function were a really big deal and were tied to bad outcomes. So the name changed to acute kidney injury. That shift is huge because an injury can be small or big, but either way, it's a warning sign that matters.
So what is it officially? Well, at its core, AKI is just a sudden drop in the kidney's ability to do their main job, which is to act as the body's super sophisticated filtration system. When that happens, waste products like urea start to pile up in the blood, and the body's delicate balance of fluids and salts gets all thrown out of whack. That's our starting point.
Okay, so here's our roadmap. We'll start with that name change. Then we'll dive into the two main clues doctors use for a diagnosis. After that, we'll see how the injury gets graded using a system called KDIGO. Then we'll get into the messy, real-world challenges of using these rules. And finally, we'll ask why this flawed system is still absolutely vital.
All right, let's jump in. How do doctors actually spot this? You know, with all the medical technology we have, you might be surprised to learn that the global consensus for diagnosing AKI boils down to just two main clues. These are the main characters of our story.
And here they are: a change in serum creatinine and a change in urine output. So creatinine is basically just a waste product that comes from our muscles. Healthy kidneys clear it out of the blood, no problem. If that number starts to creep up, it's a red flag that the filters are clogged. And urine output, well, that's pretty self-explanatory. It's how much pee you're making. If that suddenly takes a nosedive, it's another sign the kidneys are in trouble. That's it. These are the two pillars.
Let's get more specific with that first clue. One of the key triggers for an AKI diagnosis is when serum creatinine goes up by just 0.3 milligrams per deciliter within a 48-hour window. Now, I know that number sounds tiny, almost meaningless, but in the world of kidney function, a jump that small, that fast, is a massive siren going off that tells doctors something has suddenly gone very wrong.
And what about the second alarm bell? The urine output. The specific trigger here is when a patient's output drops to less than half a milliliter for every kilogram of their body weight per hour, and it stays that low for at least 6 hours. Just to put that into perspective, for an average adult, that's less than a shot glass worth of urine every hour. It's a really clear, visible sign that the kidneys are struggling to produce fluid.
So doctors have these two clues, right? Creatinine is up, urine is down. But an injury isn't just a yes or no thing. It has levels of severity. And that's where the KDIGO staging system comes in. It's the global standard for grading just how bad the damage is.
Now this system, KDIGO, it didn't just appear out of thin air. It's actually the product of years of refinement from the global medical community. It started with a system called RIFLE back in 2004, got tweaked by the Aiken Group in 2007, and was finally refined into the standard we use all over the world today back in 2012.
So how does KDIGO work? It's pretty simple, actually. It gives us 3 stages. Stage 1 is the mildest. That's often triggered by that tiny 0.3 creatinine jump we just talked about. Stage 2, things are getting more serious. The creatinine has doubled from the patient's normal level. And then there's Stage 3, the most severe. Here, the creatinine has tripled, or it's so high that the patient needs dialysis. The rule is simple. The higher the stage, the worse the injury, and the higher the risk.
Okay, so we have this clear, number-driven system. Seems pretty easy, right? Well, not so much. Because when you take this neat little rule book and try to apply it in the messy reality of a hospital, you run into some pretty major challenges.
And the first big problem is this. The KDIGO criteria are fantastic at telling you that a fire alarm is going off, but they're not so good at telling you what started the fire.
This is what experts call the etiology problem.
The definition essentially lumps a ton of different problems into one big bucket. So a patient who is just dehydrated can meet the exact same criteria as a patient who has severe kidney damage from a toxic drug. They get the same diagnosis, but their treatment and their prognosis are completely different. And you can imagine this makes it a total nightmare for researchers who are trying to develop targeted therapies.
Next up, one of our 2 pillars of diagnosis. Well, it's actually pretty controversial. Just how reliable is low urine output as a clue for a true kidney injury?
The evidence here is all over the map. On one side, you have studies saying that, yes, urine output is a very sensitive early marker and it helps predict who's going to do poorly. But then other studies find that, no, it doesn't really predict mortality on its own, and sometimes a dip in urine output just means the patient needs more fluids, not that their kidneys are actually injured. The science is just not settled.
In this last challenge, this is maybe the most practical and frustrating one of all for doctors. The whole definition hinges on seeing a change from a patient's normal baseline. But what if you have no idea what their normal even is?
I mean, think about it. A patient shows up in the ER. They're really sick. They probably haven't had a blood test in months or maybe years. So their first creatinine level is already high. But is that a double or a triple from their baseline? You have absolutely no way to know. And this is a huge problem. It means doctors can easily misclassify patients, either missing AKI entirely or diagnosing it when it's not really there.
So the system has problems. It lumps different diseases together. One of its main clues is debatable and can be impossible to apply accurately. So given all of that, why do we stick with it? Why is it still so essential?
Well, the answer is that even with all its flaws, having a single global standard is absolutely fundamental. It allows researchers all over the world to study the same thing. It means clinical trials are actually comparing apples to apples. And most importantly, we know for a fact that those stages 1, 2, and 3 are incredibly powerful at predicting a patient's risk of dying. That simple number forces a doctor to stop, pay attention, and act.
And this really brings us to the key takeaway, summed up perfectly by a panel of experts. They wrote that discretion is required to determine the clinical significance of a diagnosis of AKI. In other words, the KDIGO criteria are a fantastic alarm system. They flag a problem, but they're not a substitute for a clinician's judgment. They're a guide, not a gospel, to help doctors figure out what the numbers truly mean for the person in front of them. Which leaves us with this final, really big question. This story of defining AKI is a perfect example of a central challenge in all of modern medicine. On one hand, we have these powerful, data-driven rules that let us standardize care and do research on a massive scale. But on the other hand, medicine is still and will always be a deeply human and nuanced art. So the real question is, how do we best balance the two? How do we get the best of both worlds?